think we have everything already, so we'll go ahead and get started. I'll start with the introduction of Dr. Anushree Agarwal. It's my pleasure to invite her for today's cardiology grand rounds. Dr. Agarwal earned her medical degree from Nagpur, India. After medical school, she then completed her internal medicine residency at Southern Illinois University in Springfield, Illinois, and then completed her cardiology fellowship at the university at the Aurora Healthcare, which is affiliated with University of Wisconsin in Milwaukee. After that, she came to UCSF and completed a 2-year ACHD fellowship. Interesting fact, she was actually UCSF's first official ACHD fellow. And since then has been a faculty here. She's currently an associate professor in cardiology, director of ACHD research, and co-PI of the 2 ACHD registries. Her clinical interests include congenital heart disease and cardio-obstetrics, and her research is focused on identifying and closing the gaps in care of adult congenital patients. So it's my great pleasure to invite Dr. Agarwal, and I'll hand over the mic to her. Thank you.
Can you guys hear me okay? All right, perfect. Thank you, Evelyn, for that introduction, and good afternoon, everyone. Thank you for giving me the opportunity to present here today. These are my disclosures. ACHD in this entire talk is going to refer to adult congenital heart disease. And today I would go over some of the challenges, solutions, and future directions, let's say potential solutions and future directions in ACHD care. Let's start with understanding the current landscape of how the current landscape of ACHD is changing. You're all quite familiar with the various defects within CHD, but based on the most recent guidelines, these could be anatomically classified into simple, moderately complex, as well as complex CHD. The guidelines further added 4 physiologic states to the classification as classes A through D, based on their NYHA class and severity of association of other conditions related to congenital heart disease, such as valvular dysfunction, arrhythmias, heart failure, pulmonary hypertension, aortopathy, cyanosis, etc. Thanks to the advances in congenital surgeries and the excellent pediatric care, we have seen that the distribution of age at death in congenital heart disease patients has shifted from the pediatric population in 1980s to more older adults in 2000s. Number of children, as shown in these blue bars, born with congenital heart defects, have been stable over time, but the number of adults with CHD have increased significantly over the last few decades by almost 100%. The improved survival to adulthood is most striking for those with severe congenital heart defects, such that survival to age 18 now is expected for about 90% of children who are diagnosed with severe CHD. This is the data from Quebec, but it is extrapolated to the US estimates that there are currently about 2 million adults with congenital heart disease living in the US, and ACHD population is growing at the rate of 40 to 50,000 new patients that are added every year. So let's talk about some complex medical and developmental needs that these patients have. We have reported that compared to age and sex matched adults without CHD, those with CHD in market scan commercial claims data have more than 2 times higher health service use, and they cost $3,000 to $6,000 more than the non-CHD counterparts for their ambulatory services, depending on the CHD severity. And that cost is $7,000 to $10,000 higher during pregnancy. And from the California inpatient databases, we found that ACHD patients are 2.5 times more likely to have adverse outcomes during heart failure admissions. Also, adults with CHD are nearly twice as likely to have comorbidities than their age and sex matched non-CHD patients, and their comorbidity burden for sure increase with age. In this paper, we also describe that even the comorbidities that are expected to be less likely related to congenital heart disease, such as diabetes, renal disease, hypothyroid or thyroid disorders, hyperlipidemia, etc., were much higher for adults with congenital heart disease compared to their age-sex matched non-CHD peers. So not surprisingly, majority of these patients usually have multiple specialists and subspecialist needs that require a multidisciplinary team at a tertiary comprehensive centers. Additionally, managing mostly these young adults with chronic conditions require balancing their growing independence with their developmental, psychological, and complex medical needs. And similar to any young adult who is with chronic conditions who is transitioning into adulthood, the challenges are at multiple levels. Those of you who have a teenager or a young adult will be able to easily relate to this, but young adults aren't fully developed to handle their own healthcare. And then suddenly they're expected to now take charge while juggling their careers and relationships. Meanwhile, parents lose legal authority over healthcare decisions on their children at this young age. Some parents who stay involved feel lost in the adult healthcare system, and as they age, their caregiving capacity may decline. On the provider side, adult doctors often lack familiarity with pediatric conditions, and ACHD specialists might receive patients with incomplete cardiac histories. System-wise, these young adults age out of pediatric programs like California Child Services. Imagine losing a comprehensive coverage and then moving to something that provides less support, especially when you have a lot of chronic conditions to manage. The robust social work and other support services that are available in pediatrics just aren't matched in our adult health system. And finally, community supports like school programs disappear around the age of 18 to 21, leaving these young adults with fragmented resources that don't work together usually. And all of these challenges are further exacerbated with various social determinants of health-related factors for these patients. This is further evident in this multi-center survey study of 922 patients, where common reasons for gaps in cardiology care for these congenital heart disease patients were related to lack of knowledge, insurance or financial issues, lack of resources, and lack of social support. So as we discuss potential solutions, let's start with understanding where there is a significant gap in adherence to guidelines. The most recent ACHD guidelines emphasized as a class 1 recommendation that all adults with CHD should be managed by or in collaboration with ACHD specialists. The guidelines also describe the frequency of surveillance monitoring using the recently proposed anatomic physiologic classification system. And not only are there guidelines, but there are a comprehensive list of requirements for accredited ACHD centers in the US to manage all the complex needs of these patients. And the list of the comprehensive centers across the country is growing every year. This is because there is a strong evidence that specialized ACHD care is an independent predictor for decreased mortality in these patients. This is a time series analysis from the Quebec data again. Data from Belgium has shown that specialized ACHD care is associated with the 33% reduction in hospitalizations for these patients and about 46% reduction in pharmaceutical costs. And recently, from 13 US health centers, we demonstrated that having routine outpatient visit with an ACHD specialist significantly reduced the likelihood of a subsequent emergent admission. So the question is, are these patients receiving specialized care? It is shown in various papers that 21 to 80% adults with CHD lack the recommended care. Less than 8% of those who require care are benefiting from it. This was an estimate in 2016, and I don't think things have changed very much since then for these estimates to be any better. Most vulnerable period for gaps in care is during transfer from pediatric to adult care because of all the challenges we just went over. This is a very rough estimate from the UCSF data. I reached out to CTSI a few years ago, and we looked at all CHD patients above the age of 18 years. And using ICD codes, these data are not validated, and I haven't excluded patients who didn't meet the criteria for not needing follow-up. But overall, 75% patients from the SF location and more than 90% patients from the Oakland had no cardiology follow-up anywhere at UCSF over a 5-year period after their last pediatric cardiology appointment. So what about patients who are receiving care at specialized centers? So Joseph found that among patients who are in care at any of the 12 specialized ACHD health centers in the US, almost half of them are not in care with the ACHD specialist. So remember, these are the patients who are receiving care at specialized centers, but they're not seeing the ACHD specialist at that center. Those who didn't see an ACHD specialist also were 6 to 9 times more likely to have gaps in recommended testing. He also found that if we take into account the anatomic physiology classification system, then about 3/4 of these patients had gaps in recommended follow-up care, with the highest gaps noted in patients with severe and simple physiologic class B to D patients. This provides us with a huge opportunity to enhance collaboration between specialists and subspecialists within ACHD centers to reduce at least some care gaps. As we move forward, I want to talk about how patient-centered approach to reducing some of these gaps seem to be promising. According to the chronic care model, supporting patient activation skills, which is defined as the knowledge, ability, willingness, and confidence to manage one's health and care, can result in a highly engaged, informed, activated patient who can then have productive interactions with the healthcare system to result in reduced care gaps, better outcomes, and cost savings. A randomized controlled trial in Canada had demonstrated that nurse-led education intervention, which included education about the CHD condition as well as self-management skills, results in 3 times more likely to have timely ACHD visits compared to usual care among adolescents who are transitioning into the adult healthcare system. There are some other single center or case control studies that have shown similar results. I think one of this is from a transition clinic in the US, the others are outside US. So it is promising that these clinic-based interventions can foster patient engagement skills and timely ACHD visits. However, these processes remain poorly adopted in many US and non-US health centers. And one possible explanation is that these interventions that solely rely on the clinic-based processes are challenging to deliver due to missed clinic visits, variability inherent to delivery, whether they're delivered by physicians or nurses, and limited clinic time or variability in the available resources, example, availability of patient care coordinators or navigators. Also, clinic visits might become very overwhelming to patients, and it may not effectively reach members in the patient support community. So it is important for us to identify tools in addition to the clinic-based processes that may foster skills in patient engagement, augment individualized patient-provider care, allow efficient use of the valuable clinical resources, and are scalable. Here is where we propose a digital health tool designed using theories of behavior change. With the help of the PCORI funding, we built a national web-based ACHD registry on our own Eureka digital platform within UCSF Cardiology to collect patient-reported outcomes. And we were able to recruit about 4,500 ACHD patients across various age, sex, and CHD lesions. So we know that it is feasible to recruit diverse ACHD patients in digital health research. However, smartphones are becoming increasingly popular, and reliance for online access, especially among young adults, non-white, and lower-income Americans, is more on the smartphones. However, there is lack of any existing digital interventions to promote patient engagement skills using these digital tools. And finally, while there are digital interventions that have proven to be effective in other chronic conditions such as heart failure, diabetes, cancer, it is clear that if we if we fail to incorporate theories of behavior change, then these interventions are more likely to result in failure to achieve desired outcomes. So over the next remaining time, I will go over a digital health solution called Empower My Congenital Heart that we have developed, and I will share some of the preliminary data from this tool. We used a person-based centered approach. A person-centered approach is one in which the digital tool was designed taking into account the perspective and the psychological context of the people who will be using them. Our first step is we used components of 4 behavioral frameworks: behavioral change wheel, digital health equity, diffusion of innovation, and behavioral economics. We then conducted qualitative, in-depth qualitative interviews and engage our community partners. Our key objective was to support patient activation and engagement skills. The behavioral theories or models are methods. They are scientifically proven methods to identify factors that are likely to influence any change in behavior. The behavioral change wheel, in particular, combines a lot of theories of behavior changes and is a systematic approach to understand how a behavior can be changed. And it also helps design effective interventions. It has 3 core components at its center called capability, opportunity, and motivation, all of which interact to influence a change in behavior. Now, we use the behavior change wheel framework to define the CHD health problem in behavioral terms. Example, lack of patient engagement skills or lack of timely ACHD visits. Then we used it to understand the determinants of behavior using the capability, opportunity, and motivation model, commonly referred to as a COM-B model. And then we also used it to select the various intervention functions, that is, the means by which an intervention component changes a behavior. These could be through education, through modeling, training, and other methodologies. We also applied concepts of health literacy, readability, ease of use, and also engaged various level of adopters, so highly engaged CHD patients as well as less engaged CHD patients, and use nudge and defaults in the design phase of the digital tool. We then conducted semi-structured qualitative interviews for ACHD patients. We purposefully sampled patients to gain diversity in ACHD lesion complexity, race, ethnicity, income level, education, prior gaps in care, as well as geographic distribution. We recruited 37 patients, 27 from UCSF and 10 from outside UCSF that represents various geographic regions in the US. ACHD clinicians included cardiologists, nurse practitioners, nurse educators, as well as patient coordinators. Caitlin, who is in a joint medical program at UC Berkeley and UCSF, conducted all of the 50 interviews in English. And Karina, my clinical research coordinator, conducted them in Spanish. Each interview lasted 45 to 60 minutes, were done on Zoom and audio recorded, and expert perspectives on how we can enhance lifelong specialized CHD care. We developed transcript summaries of each interview, and for these 54 interviews, this resulted in over 600 pages of transcripts. I was fortunate to have an amazing team of student volunteers who, along with Karina and Caitlin, coded these transcripts to identify key topics and formatted them into a matrix. They then compared the data across participants and extracted broader themes or domains. So what did we find? There were 6 major categories that emerged as essential for patient engagement in ACHD care. These categories were derived from 36 lists of codes and subcategories that were identified. These included healthcare system and institutional structure, interventions related to personal development, knowledge and education, ACHD's placement in one's life. In other words, how does a patient see CHD affects their life or perceive in their life, sources of support, and identity and personal resources. We found that these categories all emerged to be interdependent. What does that mean? It means that the factors or interventions within one category could in turn influence or address the barriers within another category. Because these categories were so interdependent, three of them, as highlighted in green, emerged as the most practical, readily actionable, and impactful solutions to improve ACHD care. Patients and clinicians differed in their priority and proposed implementation of each intervention target. Clinicians prioritized healthcare system and institutional structure and suggested interventions such as an increased collaboration, EHR alerts, or advocacy for a new US healthcare reimbursement model as potential intervention targets. Patients prioritized sources of support, which included interventions such as increased provider access, community connections, and increased transparency and reassurance on daily management issues as their priority for improving care. Both clinicians and patients identify knowledge and education as one of the top priorities, such as centralization of resources, educational opportunities available outside of the clinic visits, and continuous improvement of existing materials. 4 emerging hopes from the digital tool included easy access to resources, uplifting of patient voices, customization to their needs, and positivity and joy. Finally, as we engaged our community partners, there are 21 members. These numbers are rapidly changing because the members are getting added to our community, but these include diverse patients, family members, various physicians and other clinicians, as well as advocacy representatives. We have community partner organizations. These members are involved in all aspects of the Empowerment CH planning, design, execution, implementation, and dissemination. They also help with creating, identifying, getting the name, logo, and everything identified for Empowerment CH. The logo with the arrow was chosen to reflect the primary goal of uplifting the patient voices and patient empowerment. The red, blue, and purple colors were chosen to reflect the diversity of the CHD lesions and uniqueness from other heart conditions. The Empowerment CH Digital 2 is hosted on our own Eureka Digital Research platform. The participants can join from anywhere using a QR code or a link. They can engage in Empowerment CH activities on a smartphone or on their own computers or devices that they prefer. The Empowerment CH activities, the participants receive the Empowerment CH activities every 2 months. The activities include surveys, exhibits, as well as linkages to wearables or patient portal. We also have a feature that we labeled as Poke, which is a way for us to engage participants. These are just small content messages, and their content is very variable. The timing of the pokes are very variable, but they go every other month. And the content could include patient stories, fun facts, study updates, other research studies that might be going around, and other kind of information. Surveys in Empowerment CH are meant to gather self-reported data about the participants, like their demographics, their diagnosis, health service use, patient-reported outcomes, and then various engagement domains. The 2 major engagement domains that we use are our outcome measures are called patient activation measure, as well as Gothenburg Empowerment Scale. They also are meant to collect participants' feedback on various exhibits, as well as allow patients to share their personal stories or ask questions. The surveys that the participants complete in the 3rd and the 4th month after joining allow them to automatically build their medical passport. This is a hub for their vital health information. As you all know, carrying their own medical information for our congenital heart disease patients is so critical when they, present at various locations. Once this is built, it is available for the participants within their app in the Eureka Digital platform, within the Empowerment CH app, and they just need to click on a small bar at the top of their app to access it. These are the exhibit topics for the first year that these patients receive. They are meant to boost participants' confidence and knowledge in navigating the CHD. The ones in orange are already completed and sent out to the participants. These exhibits are built using an iterative process. We have 4 work group members who meet every week to build a structure and curate all the content on each topic. These include Karina, the CRC, Kirtana, who is a Peds Cardiology Fellow from University of Miami, and 2 patients, Joe and Lindsay. Joe is a board-certified patient advocate in Houston. Dr. Hui Lin, who will be joining us as an SCHD interventionalist from Houston, introduced me to Joe. Joe has developed a design guide for EmpowerMyCH first to ensure that all the materials are uniformly formatted and are consistent, and to enhance readability of the participants. He does majority of the work related to the planning, editing, and formatting to elevate the experience for patients. Lindsay was a single ventricle patient. She is now 1.5 years or more out from her heart-liver transplant from UC San Diego. She lives in San Diego. She has also recently been leading our participant engagement efforts. Our work group members then work closely with our internal UCSF team, Karina, Robin, and Jennifer, who provide guidance for all the content that is created. All of this materials is then reviewed by our community members for further inputs. And there are very frequent meetings that happens in order to get each topic content prepared. It takes us about 3 to 6 months to really finalize one whole packet, usually. The content of the exhibits include knowledge-based information. Sometimes we end up addressing some of the questions that the participant might have asked while in the study. It also includes empowerment and peer empowerment messages. These are motivational, confidence-building messages from clinicians and patients respectively. They are designed to persuade the participants using emotion, optimism, and social influences. More recently, we have started incorporating trivia questions within these exhibit materials so that the participants can be more engaged with the material and could also help them remember or retain information as they review this. With a single tap inside the mobile app, some of the mobile app users, all the mobile app users can also have easy access to sharing the experiences or asking questions to other peers. This is not a direct peer-to-peer chat box. This is just a questionnaire. They can ask those. These are all vetted by our research team and IRB before we share them out to other participants. They also has an easy access to the ACHD clinician directory. So ACHA, Adult Congenital Heart Association, has put together a directory of all ACHD providers. So if patients move or are looking for a second opinion, they can easily find providers. It also has a link for community events. We update it almost every month. And so participants can find events happening around their area. And finally, it's not shown here. There is also a link for resources. This takes them to our EmpowerMyCH webpage that is also built by Joe entirely. And it also has all of our exhibits and resources for patients to have easy access to at any time. So we launched in September, on September 5, 2024. We primarily recruited patients who already exist within the Eureka infrastructure. And we have recruited 400 patients and consented about 365. This has been our initial experience in the first 6 months. Our demographics reflect the demographics of patients within other Eureka studies. So a lot of females, a lot of people with, that self-identify themselves to have PB white race. Our baseline Gothenburg Empowerment Score, again, Gothenburg Empowerment Score is a measure that is a validated tool that is specifically built for congenital heart disease patients, and it measures how confident they are in managing their healthcare. We have a highly empowered group that we have recruited so far. Our median empowerment score is 62. The range for a score could go from 15 to 75. and higher scores indicate higher levels of empowerment. We use a score called Client Satisfaction Survey to gather information from the participants on how satisfied they are with using Empowerment CH tool. There are 8 questions within the CSQ, and their score range from 8 to 32, with higher scores indicating higher satisfaction. We collect this information every 6 months. So since we just crossed a 6-month mark, about 130 patients, completed this information. Our median score is 24, which suggests high level of satisfaction, and it is very comparable to other digital health research studies that have been published in the literature. These are the 4 exhibits. The participants, more than 90% of the participants have rated these exhibits to be helpful. The group in the not helpful group have mostly commented that these are participants who are in the medical health system, either as physicians, nurses, or in other capacity, or are advocacy members at ACHA, and they are already quite familiar with how to navigate the health system and know this information. The feedback we have received so far have reflected quite positive comments related to the readability and accessibility of this information. They feel that the information is reliable and comes from credible resources. It has helped them build motivation by, people have commented on how it has helped to build self-advocacy and self-efficacy skills. It has enhanced opportunities for them to use this information on a day-to-day basis. And participants have also commented on how it has helped them build capacity by enhancing their knowledge in areas that they were not aware of earlier. And we're very happy with this feedback, mainly because as we saw, majority of these participants are already coming as a highly empowered group of participants. Participants have also identified various topics that they would like to have more information on and would like to see more research come out on. So in summary, the intervention components within the Empowerment CH, which are the medical passport, peer guidance, and peer connections, function as tools for providing education, training, modeling, persuading the participants, enabling them, or restructuring their environments to enhance their capability, opportunity, as well as motivation, or otherwise referred to as the COM-B domains for ACHT patients. Our hypothesis is that this will support ACHT patient activation and engagement skills, ultimately improving patient experience, reducing gaps in care, and improving health outcomes. So as we talk about the future directions, we are working currently on active recruitment. We started working with CTSI, and this is going to be our next big push for recruitment that is coming to us in this week or the next week. We're just waiting for IRB approval on that. We are working on trying to engage more younger adults in this group. Juhi, who's one of our student volunteers, graduated from UCLA. She connected us with the Saving Hearts Foundation group at UCLA. These are undergraduate students who are raising awareness about heart disease and are connecting patients with essential resources. Juhi and Lindsay are working together in reaching out to other school health and volunteer groups in various other colleges to see if we can figure out, where these patients are and help them get back into care. We're also working and collaborating with various transition clinics so that we can encourage more of the younger patients to be involved. Because we are working on our social media channel. Lindsay is taking a lead on that. We are constantly refining our retention and engagement approaches, constantly exploring ways how we can make this better and have more people continue to complete all the activities and be involved. We hope to work on adapting this to the Spanish-speaking users. We also hope we can adapt this to the adolescent age groups who are 14 to 18 years, because then we can start it at the early stage of transition to help them understand how to navigate the adult health system. And then eventually we plan to conduct a hybrid implementation effectiveness trial to study the effectiveness of empowerment CH in actually reducing the care gaps. Empowerment CH has a lot of opportunities for collaboration outside the patient engagement intervention. It is a very adaptable infrastructure. So, anybody comes up with the future intervention components, for example, a mental health intervention or a physical activity intervention, or any other important patient education materials, these could all be implemented and tested within our existing infrastructure. There are opportunities for a lot of linkages. We collect a lot of patient-reported outcomes data using many of the validated surveys. And so if there is a valve trial or a PAH trial, or if we have like a surgical trial in congenital heart disease patients, we can always link them to these patient-reported outcomes. We do have the opportunity to collect MyChart and patient portal information, or participants link to their MyChart patient portal information. Down the road, this could allow us to develop some interventions using patient portals, such as appointment reminders or anything else that we could think of. And finally, separate from Empowerment CH, we recently started our work on our PCORI-funded project. Again, thanks to Hui for connecting me with a highly motivated and fantastic group of patients from South Central US, who he has trained them to conduct research. Our goal for this particular PCORI project is to understand the research priorities of the underserved population in South Central US, so that the care can be improved in areas that has the least opportunities or access. We are using a structured methodology for question development and prioritization called SEED methodology. This was described by Emily Zimmerman from Virginia. Our goal is to develop some patient prioritized research questions that can be further tested in future competitive effectiveness trials. We hope that this whole process will build an infrastructure for our research program at UCSF to expand our stakeholder engagement work in other underserved areas that we can then work on improving care. So, in conclusion, ACHD is a rapidly growing population, and the biggest challenge in these patients is that they are lost to care, mostly due to their complex medical, psychological, and developmental needs that our current health system is less prepared for. To reduce these care gaps, there is a need for ongoing systematic approach to identifying strategies at various levels. And while we have just started to scratch the surface of the patient engagement using digital health solutions, there is a lot that needs to be done at every level. I want to spend a couple minutes on this slide because there are so many people I want to thank you, and I could not include everybody in this one slide, but I am really deeply grateful to all my mentors for their guidance at every step with their expertise. It's truly a pleasure to work with my outstanding research team. We call ourselves as ACHD.care team because we believe that our research team stands on 4 pillars of community advocacy, research, and education. I am fortunate to have an amazing and supportive ACHD section who are always eager to contribute. Not included here are our fantastic pediatric colleagues who have always been very collaborative. I'm very proud of these student volunteers. Caitlin and Elise are already in medical school. Juhi and Pranav are heading to medical school next year, and Kevin will be finishing his master's in clinical research this year. And I forgot to mention, Karina, our CRC, is also going into a master's in public health program next year. So we're sad to lose her, but very happy for her. These hardworking residents and fellows add a lot of joy to my work. And special thanks to Eureka team, and extra special thanks to Parang, who really always go for an extra mile to help us with all our digital healthcare needs for these patients. Finally, I deeply value all our Empowerment CH community members. And lastly, thank you all for taking the time out in the middle of the day to come and listen to me. And I am happy to take any questions.
Thank you, Dr. Agarwal. I think it's, our congenital patients, especially they're on the younger side too. So I think the Empower My CH app using technology is a great way to really bridge the gap for these patients. So we'll open it up for questions now. For people on Zoom, feel free to raise your hand or leave any questions in the chat. And then for people here, just raise your hands or holla at me.